Hi, I'm Simon Ravichandran. I'm one of the co-directors of the Clinetics Rejuvenation chain of aesthetic medical clinics in Scotland, as well as the Aesthetic Training Academy, the establishment for training doctors, dentists and nurses in aesthetic medical procedures.
Hi, I'm Emma Ravichandran. I'm an aesthetic dentist and I'm a co-director of Clinetics Rejuvenation chain of clinics, the ATA in Glasgow as well.
5 years ago, we formally established a dedicated training venue in Glasgow, the Aesthetic Training Academy. And from that, we started to develop dedicated training programs to teach people right at the very beginning of their aesthetic medical career, fundamental principles and techniques. And then we developed a series of programs to enhance and develop those delegates so they could become expert injectors in a much shorter space of time. What we've done with this video that you're going to see is a kind of amalgamation of that process. We're going to take a patient who's never had an aesthetic medical procedure before, but really wants to enhance her appearance to improve her quality of life.
In this video today, we're going to take you through our patient's journey with us. We're going to look at the assessment, the diagnosis, the treatment planning, and the treatment for our patient today. We're going to look at the best products and the most safe and efficacious way to deliver that product to the targeted area to give the patient the most natural and excellent results. It's quite a funny story how I started in aesthetics. Simon and myself got married in April 2002. My whole family were at the wedding, but my mum in particular felt really amazing on the day, and the photographs reflected her confidence and the joy that she experienced on that day. Now, obviously, I thought that that was because, she was so pleased that you were joining our family. But later on, she confided in me that a couple of months prior to the wedding that she had had botulinum toxin injections, and how this had really enhanced the whole experience of the wedding, and how much confidence she had after having a glabellar toxin injection of botulinum toxin. And she encouraged me. She said, "Emma, this is something that you as a dentist can do within the United Kingdom. So would it be something that you would be interested in doing?" And I kind of mulled that over for a couple of weeks. And after a couple of weeks of thinking, I thought, if this is something, a treatment that can really give somebody that much confidence and really enhance their life that much, then this is definitely something worth looking at. So I embarked on my first introductory course to botulinum toxin and dermal filler. And then the story just carried on from that point.
So I went on that introductory course with Emma just to find out a little bit about what it was all about. I went on this course, no expectations. I just thought it would be an interesting thing to learn how to do. But at the time I was an ENT doctor, and we were treating some patients with facial palsy, and we started using botulinum toxin as an alternative to some of the more surgical procedures we would be doing. And I found that we got such a considerable improvement in our patients' quality of life. When I reviewed them at the outpatient clinics a few weeks later, they would really describe to me how happier they felt, how much more comfortable and confident they felt when they looked in the mirror in the morning. And that was the point when I realized that we had the ability to make such a significant impact on a patient's quality of life with such a small intervention. So that really got me started in the whole idea that this is something that maybe we should be doing. Maybe we should be offering a little bit more as part of our day-to-day practice.
And then, Simon, both of us attending that course together, and both of us having shared experiences in learning about botulinum toxin and dermal fillers and experiencing the positive impact on our patient's life, really give us the drive to learn more about aesthetic medicine. And I guess it really helped that we were there to support each other and go to different courses. And from that point on, we went to course after course. We bought books. We travelled across Europe. We went to Monaco. We went to conferences like FACE. And what really inspired me was watching medical practitioners who would stand up on stage, who would assess a face, who could see things or make me see things that I couldn't see, and work out a treatment plan that was completely unique and bespoke to that patient, and deliver a treatment in a really safe and efficacious way deliver results that I could never believe that I could achieve. And that's what kind of really inspired me, because I thought to myself, how can I be that person? How can I be that good? Not how can I stand on stage and do those treatments, but how can I be that good in my own clinical practice? And I think that was really the inspiration behind our success.
About 5 years into our progress of learning and trying to find out as much as possible as we could about aesthetic medicine, we went to the AMWC conference in Monte Carlo, and Emma and I sat and we saw such a huge number of international key opinion leaders, global experts in their field, and as Emma said, standing on stage describing things about their patients. We couldn't see, we had no comprehension that these were actually things that we could be affecting and would be impacting our outcome. So that was the turning point for me at least, where I kind of thought that instead of this small thing that I was doing being a small part of my practice, we've actually got the potential to make this the majority of our practice. So that was a pivotal point. We started looking at ways of reducing our mainstream healthcare service delivery and enhancing and increasing the service we could provide with aesthetic medical procedures.
And ultimately, I think the driving inspiration for us now is seeing the happiness that we can deliver to our patients, but also our staff as well, and how we've developed as business owners and how we can really positively impact their lives, the lives of our staff, and indeed our own quality of life as well. To me, true beauty is a patient that comes back to our clinic after having a treatment, feeling more comfortable, more confident in the person that they see reflected in the mirror as truly who they are. We can use formulas and guidelines, but they must be guidelines. For me, we must be able to provide that professional aesthetic eye and override those formulas where necessary in order to create a treatment plan that is bespoke for our patients to create their true beauty.
Absolutely right. You want me to tell you where to inject on someone's face and how much to use to make that person beautiful. You want a code that tells you that if you inject here and here, you're going to lift the cheek and you're going to sharpen the jawline and you're going to make your patient beautiful. But it is not like that. Beauty is how someone feels when they look in the mirror and they see that image reflecting back at them. So what we can do is aim to use our products, our techniques to restore a more youthful appearance, to make our patient's reflection reflect what they think they should be seeing. And from that process, sure, we've got the golden ratio, we've got the rule of fifths, we've got horizontal thirds. There are so many different mathematical formulas and algorithms that we can use to tweak and to fine tune, but it's a blend of everything. The first principle of beauty, the first principle of restoring beauty in a patient is having a conversation with that patient and explaining what beauty means, and then explaining what procedures we can do to help them achieve their perceived reflection.
My philosophy on treatment is that they should be as safe as possible for our patients and as efficacious as possible. As aesthetic practitioners, we really need to understand a patient's anatomy. We should be able to assess a face and create a bespoke treatment plan for that individual patient. We need to then pick the product that is going to most closely mimic the tissue that we are replacing and choose a technique which is going to deliver that product safely to that tissue by combining all of these factors to create the best outcome for our patients.
Ask yourself, what is the hallmark of a good aesthetic treatment? Is it a bigger lip? Is it a smooth forehead? Is it a lifted cheek? I don't think so. The minute it looks like they've had a treatment, the minute it looks like the lips have been filled, the minute it looks like the forehead has been frozen, it's artificial. So that's a bad result. My philosophical approach to treatment is that whatever I do, it has to be unnoticeable. You've got to see the improvement, yes, but that improvement has not got to be tied back to a treatment. So that person's friends and relatives will not look at them and say, what have you had done? Where did you go? That's a bad outcome. So I start with that as the principle. Then I move backwards. What product am I going to use? What methodology am I going to use? Well, I'm going to use the product that's going to give me the result, and I'm going to use the product that's going to have the safest long-term outcome for that patient. The treatment has got to have the least amount of downtime for the best possible result. And the delivery methodology, the needles, the cannulas, we use TSK Steriglide cannulas, we use TSK needles because we feel they give the best possible result with the least amount of trauma. Today, we're going to treat a patient not with a paint by numbers approach, not with a code beautification, inject here to get a result. What we're going to do is look at the areas of volume loss and address them appropriately with the right technique, the right needle, the right cannula, and the right product to get a physiological, natural aesthetic outcome.
So with our patient Angela, we are going to use bilateral volume to restore volume loss really globally across the whole face, in the temples, in the mid-face, in the chin, and in the perioral area. So we're going to choose that filler, we're going to choose that cannula, and we're going to hopefully demonstrate the best techniques to get the most safe and efficacious result that you can within your clinic.
Hi, I'm here with Angela. Angela is definitely one of my favorite sorts of patient that we get in our practice. And there's two reasons for that. One, she's not had anything done before, so we have a blank canvas to work with. And secondly, because she's not come asking for a treatment. She's not come saying, Simon, I need you to put toxin in my glabella or filler in my lips. She's come because she looked in the mirror and she felt that she looked a bit tired and she wanted to improve her appearance. Simple as that. And this is great because that means we can take a step back and start thinking about a global approach, not a line, not a filler, not a treatment, not a methodology, but a philosophy almost of assessing, managing, communicating, and treating our patient. So the first thing I did when Angela walked in through the clinic door is we look at her face. We look at the way she smiles. We look at the way she walks. And then the mind starts to kick in. The techniques, the processes that we learned right back at the beginning of starting our aesthetic practices, so the grids, the formula, the proportions, all those hit the mind very, very quickly. And we make these split-second judgments and decisions about what is aesthetically ideal and what we can do. So we take that and then shove it on the back shelf and start thinking more holistically about the whole face. We'll come back to the maths and the formula later on, but we need to consider the harmony, the balance, the flow. What makes the face shape attractive? What has happened to the face shape to make it look aged and tired? And that's the point that we can start from and then work back and figure out what we're going to do about it. My first impression was from the front view of Angela, and my mind did its thing and it splits us into upper thirds, which is from the hairline to the glabella, and middle thirds, which is from the glabella to the subnasale, and then from the subnasale to the bottom of the chin as the lower third. And I thought, okay, well, the upper third matches the middle third, but the middle third looks, because it isn't always apparent when we measure it, but it certainly looks like it's a bit short. So we might start thinking about elongating the lower third. And then we move on to the second stage of this sort of mathematical grid-like assessment, and we start thinking about vertical fifths rather than horizontal thirds. And the central vertical fifth is the most important one, because that's the one that never changes with age, or the intercanthal distance, the distance between the two medial canthi, never change with age. So we use that as a baseline, as a reference point. And I know from the anatomical textbooks and what the artists tell us, that if we drop a vertical line from the medial canthus, they should intersect with a line that approximates the edge of the nostril, the alar edge. So the alar base width should approximate the intercanthal distance. And we also know that the alar base width and the intercanthal distance should approximate the width of the chin. So that gives us a rough landmark, a guide to start from. And I'm looking at Angela thinking, well, you know what? We can actually narrow this a little bit. Would that bring it more into harmony? Would that improve the balance? And we can narrow the chin. Would that improve the harmony? Would that improve the flow? Now, it's not just a question of I see it, it's mathematical, I'll do it. I see it, it's mathematical, what difference will it make? So what do I see when I'm looking at Angela? Let's think from the top and then work our way down.
So I'm now going to assess Angela's upper third of her face. So Angela, we're going to look from the hairline down to the lateral acanthus. Lift your eyebrows for me, Angela. So we have a few horizontal lines on Angela's forehead. Relax again for me. And now I'm looking at the contour of the upper forehead or the upper third of the face. Laterally, we've got an ideal curvature. The curve of the female forehead should be approximately 10 degrees. But centrally, we can see a little bit of dip in the central forehead, causing an irregularity to that natural curve of the forehead. That depression is causing a little bit of depression of the medial brow. So restoring that volume would not only improve the contour of the upper forehead, but also lift that medial brow. I'm now going to move from the forehead into the temples. Now Angela does have a nice curve from the forehead into the temples, but we can see on her left hand side that there's a little bit more of a volume loss, which is translating into more heaviness of her upper eyelid. There is a little bit of a step between her forehead and her temple, so in this case I think that it would be prudent to put a little bit of dermal filler into her temple area in order to replace the volume loss, leading to restoration of elevation of the lateral brow and projection of the lateral brow and improvement in the overall appearance of the eye area. Smile for me, Angela. In this area, Angela really doesn't show any crow's feet at all, so therefore I wouldn't be encouraged to use botulinum toxin in this area. However, if you screw your eyes really shut tight for me, Angela, please. We can see the depression part of the orbicularis oculi is pulling down on that eyebrow, so maybe a small amount of toxin in the lateral brow would also help with the elevation of the brow, which would improve the overall aesthetics of this area.
So we're here now with Angela in the treatment room. We've had a conversation about Angela's expectations and goals from treatment, and we've decided on a treatment plan that suits Angela's requirements, her expectations, her availability for downtime, and we've gone through the consent process. We've taken good quality three-dimensional photographs that we can refer to and reflect on, and we're ready to go, aren't we?
We have, and we've also used the ultrasound upstairs just to sort of vascularly map out Angela's anatomy, which we can actually use during this process as well.
Absolutely. So we're going to use a combination of botulinum neurotoxin. We're using Xeomin, and we're going to be using some dermal fillers, and we'll be using the Balatera range of dermal fillers with the TSK range of needles and cannula. Now, because we're using both toxin and filler, we prefer to start with toxin.
Yeah, we'll go for toxin first, predominantly because we can make a good assessment of the action of the muscles, which is not impacted by the local anaesthetic that's in the fillers, and potentially the swelling that can happen immediately after dermal filler placement as well. So I think let's have a look at Angela's musculature and let's get these lines relaxed.
Okay. We're going to start by having a look at Angela's glabella complex. Now I'm going to assess this first by pushing the skin together and looking for the creases, and then I'm going to feel for the muscles using the finger and thumb of my non-dominant hand. So when we push the eyebrows together, we can see clear lines running vertically from the medial point of the eyebrow, another line running vertically from the medial part of the eyebrow, and another line running vertically, just medial to the head of the eyebrow on the left-hand side. And I know that the muscle, depressor corrugator supercilii, attaches to the nasal process of the frontal bone. And when I palpate it between my finger and thumb, we can feel it underneath the skin. So I'm going to put a dot just where I can feel the medial head. Laterally, the the muscle inserts into the skin around the mid-pupillary line, just above the supraorbital ridge. We'll repeat the process on the other side. I can palpate, and I know that the head of the muscle attaches to the nasal process of the frontal bone. So I mark exactly where I can feel it between my finger and thumb. And I know that the tail of the muscle inserts into the skin just above the supraorbital ridge, roughly around the mid-pupillary line. We can visually identify this by asking the patient to frown repeatedly, and we can look closely for little indentations in the surface of the skin when we do this. The final injection point for the glabellar complex is the procerus muscle. The procerus is an inverted fan-shaped pyramidal muscle that inserts into the osteocartilaginous nasal dorsum, runs superiorly, spanning laterally and laterally on the other side in a triangular shape to interdigitate with the muscles of the corrugator complex and frontalis, as well as inserting into the skin. The best place to inject this muscle is the midpoint of the medial canthus. Now, I'm going to move on to have a look at the horizontal forehead lines. The muscle responsible for this is the frontalis muscle, and we can demonstrate this by inspection, by palpation. Could you raise your eyebrows for me and relax? Can you raise your eyebrows for me and relax? And we can see that muscle extends laterally as far as the tail of the eyebrow on this side. Raise your eyebrows for me. I can see that it's extending laterally as far as the tail of the eyebrow on the left-hand side. Raise your eyebrows for me, relax. Raise your eyebrows for me, relax. And you can feel the contraction of the muscle underneath the skin. I can see that there's a superior area of contraction. Raise your eyebrows for me. There's a superior mark that corresponds to the uppermost area of the contracting muscle. And this gives us an area to inject, doesn't it, Emma?
Absolutely.
So we tend to split this into 5 or 6 injection points because we know the diffusion of toxin is usually about 1 centimetre from the injection point. And then we have a closer look to see if there's any additional areas we need to inject that might be out with those diffusion zones. Could you raise your eyebrows for me again? I think there's just a little bit of movement at the top here. Raise your eyebrows for me as high as you can. A little bit of movement superior laterally there. And then the last injection point on the upper part of the face is that superior lateral orbicularis oculi, the depressor muscles of the tail of the eyebrow. Can you screw your eyes tight shut as far as you can? And relax. And do it again. And relax. So we can see that that dot moves inwards when she screws her eyes tight shut. Screw your eyes tight shut. And relax. And tight shut. And relax. And that's great because that movement is caused by the orbicularis oculi contracting, pulling inwards. So weakening of this muscle should result in a slight superior lateral lift, giving a more youthful appearance.
Absolutely, and also the relaxation of the corrugator complex is going to give you a medial brow lift as well, which is going to complement that lateral lift on the tail as well, really completing that natural look that Angela's looking for.
Thank you. Our first injection point is the procerus muscle. Typically approach this from above. We introduce the needle just through the surface of the skin, typically a depth of, 4 millimeters or so each time?
It's about half the depth of the needle.
We slowly inject about 0.1 mils, which corresponds with this Xeomin in the standard dilution to 4 units toxin. The second injection points are the heads of the corrugator muscles. To do these, again, I lift them off the bone slightly between my finger and thumb. And again, introduce the needle close to where my dot is and slowly inject another 0.1 ml, which corresponds to 4 units. We'll repeat the process on the other side. 3, 2, 1, 0.1 mils. And then we inject into the tail of the corrugator muscle. That's where it inserts into the skin. A lot of textbooks say that it's always medial to the mid-pupillary line, don't they, Emma?
Yeah.
It's not true. Little scratch.
No, these injections should always be based on a thorough assessment of the muscle.
Yeah, absolutely.
And treatment of the muscle, the individual muscle of the patient.
And you can see how superficially I'm injecting here. So whereas with the medial injections, 1, 2 and 3, are relatively deep, just injecting into the skin or just underneath the skin.
Can you do that?
Got me.
So again, just a superficial injection.
You see,
We're using an invisible needle, which is a very comfortable experience for the patient. And as you can see, there's no marks or no bleeding.
so now moving on to the frontalis muscle. We're aiming for the muscle. Now it's really difficult to target the muscle in this area, isn't it, Emma? We've been doing a study looking at the depth of the muscle from the surface of the skin, the thickness of the muscle. And at this point we haven't published anything yet, but generally speaking we find that the muscle is about 3 millimeters below the surface of the skin. And when everyone has an ultrasound scan, we can scan all our patients and gauge exactly where we need to be. I'm only doing 2 units per injection site here. And the reason for that is because we've got that degree of laxity. And as we age, the frontalis muscle holds the eyebrows up. Kind of counterbalances the normal laxity and descent that we get with age. So the muscle gets stronger, and what happens is we inadvertently over-weaken it and we get a resultant droop.
Heaviness to the brow.
Exactly.
And so what we want to do is mostly medial elevate, lateral elevate the brows to give her that fresh look. Also, Angela wants to keep a little degree of movement, and I think that's actually really important whenever patients get slightly older as well, just to maintain that natural result.
It's got to look natural. Turn the side for me. So this final injection on this side, just into the tail of the eyebrow. Now this is into orbicularis oculi, superior lateral fibres. These are the muscle fibres that if we relax, we will get a resultant slight lift to the eyebrow on that side. Will you do the other side?
And this is again an incredibly superficial injection. This is an area that a lot of practitioners find bruised because of the plexus of vessels that are superficial in this area. But again, I find good inspection and using the invisible needles almost always guarantees a good result with no bruising.
Practically never bruise a patient with this. So we're looking at a depth of the muscle here of about 2 or 3 millimeters. This has always been a difficult thing, hasn't it? Because we're targeting the muscle, but we don't know where it is.
Yeah, it's a very, very thin muscle.
It's a very thin muscle. It's a variable depth, and if you go too deep, you don't get a good result. So we've been doing an ultrasound study that's not published yet, but we've got a couple of 100 patients. Unofficially, what we found is that the muscle is usually about 2 or 3 millimeters beneath the skin. There is a degree of variability. When the patient elevates their eyebrows, it tends to double in thickness, making it easier to target. So I aim for about 2 or 3 millimeters with each of my injection points. And ideally, when we all have ultrasounds, we'll know the depth for each one. So we'll wait and see what happens.
And here you're using 2 units.
That's right, it was just 2 units per injection each time here.
And that's really important, isn't it? The dose, the depth, and also the needle.
Yeah. I mean, the dose-wise 2 units, because 4 units may give too much of a weakening of this area, and you can drop the eyebrow, particularly in an older patient. And we want to avoid that heavy eyebrow look, so we need to keep it as subtle as possible. So the dose varies between 2 and 6 units per injection, but for Angela, based on our assessment and her expectations.
And we have to respect what Angela wanted, which was elevation of the brows, not depression of the brows, and we're going to get that medial lift with the relaxation of the corrugator complex and a lateral lift with the injection into the depressive part of the orbicularis oculi.
Yeah, I mean the goal is a fresh and natural looking result. We'll start with dermal filler injections in the temple area. I always mark, we've been doing this for 16 years and I still mark my anatomical boundaries every time I do it. I think it's a good habit to get into, and it will potentially get you out of trouble from time to time. So the upper limit of the temple is the frontotemporal crest, which you can feel beneath my thumb. The anterior border of the area we're going to be injecting is the posterior rim of the orbit, which consists of the zygomatic process of the frontal bone and then the frontal process of the zygomatic bone inferiorly. And then the inferior border is the superior part of the zygoma. And this delineates an area that we're trying to treat. The temple is a much bigger structure. It extends to the back of the head almost. But the area that we're interested in, and particularly in Angela, is actually just this area around here. We're just going to blend the junction between the forehead and the temple. I'm going to use a 22 gauge cannula to get into the area I want to go, which is the interfascial plane. Yeah. So there's obviously multiple ways to inject a temple. You can go subcutaneous, you can go deep onto the bone. The interfascial plane is the gap between the superficial temporal fascia and the deep temporal fascia, otherwise known as the temporoparietal fascia and the temporalis fascia. The nomenclature can be confusing, but it's a relatively avascular plane. Reduces the chance of vascular problems, it reduces the chance of bleeding and bruising, but from an aesthetic outcome, filling that plane gives a very natural result. Now, because that's the plane I'm going for, I'm going to use a 22 gauge 2-inch cannula, and my choice of tool there is specific to the area that I'm going to be treating in this area, because I want one that's first long enough to reach where I want it to go. It needs to be large enough to be, or rigid enough not to be so flexible it might pop up and pop down throughout the planes. And the edges of these cannulas are a little bit blunted, aren't they? So they're not pointed like some of the bullet tip cannulas, which means they're less traumatic as they go through it again, reduces the chance of any complications.
The great thing about the Steriglide cannulas are that the port is right at the tip of the cannula, while other cannulas have got that port maybe 2 to 3 millimeters back. Whenever you've got that cannula inside you, you know that you are placing your product really accurately at the right place. And I think this has really changed my practice.
Yeah, I would agree with that as well. Now, we've already scanned Angela upstairs. We did the ultrasound.
Yes.
We did the ultrasound scan to make sure there's no abnormal anatomy. We're not going to get any surprises, and luckily there's not. She's got perfectly straightforward superficial temporal arteries, exactly where I expect them to be.
Yeah, and deep temporal arteries as well, we were able
Absolutely.
to see on the bone.
So let's go forward and see if we can get a cannula in, shall we?
Let's get the temple done, and we'll also be able to see the Steriglide cannula inside you.
Yep, let's do that. Okay, there will be a little scratch this time. Okay, 3, 2, 1, there we go. Tend to leave the needle in the skin for a few seconds. Helps to make sure I'm not in a large blood vessel. If I am, there may be a flush of blood.
And I noticed that you've just gone under the skin, Simon. You haven't sort of gone deeper through the muscle or towards the bone, which I always find helps with minimising the bleeding.
Perfect.
Just wait.
Little pushing sensation. So I'm going to pinch the skin between my forefinger and thumb, and that elevates the SMAS plane towards me a little bit. So that's made it a lot easier to pass my cannula through the SMAS plane, and I know I'm through the SMAS because when I lift this tissue up, it's gliding around the end of my cannula. If I was under the SMAS, when I would pinch this, it would push the cannula back up. So now I'm deep. I'm going to keep that pinch so I know I'm in the deep plane, whilst maintaining a downwards force, slowly rotating and twisting the cannula. I'm going to elevate upwards. Into the temporal fossa. Now, the reason we use this approach is anatomical. The interfascial plane of the temple is continuous with the fascial planes of the midface. So the superficial temporal fascia, or temporoparietal fascia, is continuous with the SMAS of the midface. So if I'm under the SMAS in the midface, there's a reasonable chance I'm going to be underneath the temporoparietal fascia in the temple. So it's gentle pressure, finger and thumb on the syringe, no more than this, rotating and applying gentle pressure towards the direction I want to go. Now let's check we're in the right plane. Okay. So those are little curved branches of the superficial temporal artery. They're not the temporal artery itself, but branches of it. We're too anterior, but we can see that the cannula is underneath it.
You can see they're a little bit more active now that there's been that little bit of trauma in that area. So can we see the filler actually being deposited?
Yep, I'm going to turn the Doppler off. Okay, so I put a bit of pressure on the plunger now. You can see it's slowly starting to fill out that interfacial space. Okay, can you just show where the filler is there?
I can. So this is the hyaluronic acid filler in between the superficial temple and the deep temporal fascia.
Okay, so I'm using a molding pressure. Nothing firm. We don't need to really plasticize this into the place it needs to go. I'm just gently rolling my finger down to help create that blend between forehead and temple. Of course, we can change the direction of the cannula a little bit, keeping in the same plane. Now, for a filler like this is a relatively volumizing filler. We're actually using bilateral volume. We don't need that much. It beautifully spreads out in that fascial plane. So we've used about 0.3 ml, and I think that is all we're going to need. Can I take a swab, please? So then there's just gentle pressure on the area. Remove the cannula. So we've taken the cannula out. Now, with this sort of filler, this bilateral volume, it's got a degree of plasticity, degree of elasticity, and cohesivity. And these are the characteristics of this filler that gives it its lift without being stiff. And there's lots of ways you can use this filler based on those properties. And one of the things I like to do after treating an area like this, so sort of a flat envelope as I call it, an area in between two fascial planes, if you apply pressure to it, like firm, consistent pressure for a good 45 seconds, maybe a minute, I think what we're doing is we're smoothing it out. We're creating almost like the filling of a cake between two layers, if that makes sense. So, you know, if there's any irregularities with that product when it first goes in, and that's technique dependent, and there shouldn't be because I'm doing it, but there may be. So applying that bit of pressure just gives it that smoothness. And you see, I'm not pushing, I'm not poking, I'm not rolling or massaging. It's just a firm, uniform pressure over the whole area, trying to get that product where I want it to be. Now, there's a link between the temple area, the frontal area, and the eyebrow. So the next thing we're going to do from a similar entry point is go into the SOOF, the superior orbicularis oculi fat, which is a fat pad underneath the tail of the eyebrow. Loss of volume and attenuation results with age, and that contributes to the descendance of the tail of the brow and an element of hooding of the eyelid. So we're going to find that, and just like we mark the temple, I always mark the SOOF, I always mark everything. So we've got a medial boundary, which is the fascial boundary of the supraorbital neurovascular bundle. We've got a superior boundary of the SOOF, which corresponds to the inferior frontal septum, which relates on clinical inspection to the first incomplete line. And then there's the inferior boundary, which is the orbital retaining ligament, which we know is not just something that's associated with the tear trough, it's something that goes all the way around the orbital rim. So this gives us the medial, superior, inferior boundaries. The roof is the orbicularis oculi muscle, and the floor is the periosteum. Structures running through it, the relationships of the neurovascular bundle medially, nothing else really of significance. So I'm going to make a new entry point, just a little bit closer to the tail of the brow. Little scratch here, Angela. There we go, well done. Again, same as last time, just underneath the skin. Hold the needle in place for a few seconds. Make sure there's no blood coming up through the hub. Okay. So we've engaged the skin. Same process as we do for the temple. We want to go deep and then angle up into that fat compartment. So we just need to gently guide it through. There we are. So I can feel the tip of my needle, just here. And again, we're using Balatera volume. It's a volumizing filler. It really helps replace lost fat compartments. It lifts it gives that sort of three-dimensional lift rather than a structural pivot. It's as if it fills that space.
It's a lovely filler to use for volumization because of its cohesive rheology. I find for patients that they find that this integrates really, really nicely into the tissues and feels like their own fat. So it really feels like a natural replacement of their own fat. How much filler are you using?
0.1 mil so far, I think.
Small amounts to create a good lift, isn't it?
It depends on the filler you're using. You get a lot of lift for a small amount of filler with Balatera volume. So we're down to, it's just 0.1 that I've used. Okay, 0.2. Again, pressure over the area. Thank you. So just like with the temple, I like to apply a degree of pressure after the treatment. I do the same with the tail of the eyebrow for the SOOF volumization. And when we've done this, we're going to be moving forwards or inferior medially around the side of the face to the anterior cheek to complete that flowing, that creation of harmony from the different zones of the face, from the forehead to the temple to the cheek. Thank you for watching this video. When we teach this in our training academy, we use combinations of ultrasound, three-dimensional videography to really assess our models and really demonstrate where our products and where our cannulas are going. If you'd like to learn more, please get in touch with us at www.ataglasgow.co.uk. The midface is defined superiorly as a line that runs across the top of the zygoma.
And on this case, what I propose is that we augment the piriform floss. I still consistently mark the cheek. Should show reflection.
You can see the cannula running.
Then I can start depositing small amounts. We're going to hold the needle just at the periosteum.
Depth of the bevel is important. If we have a long bevel and we inject perpendicularly down,
We've got narrowing of this nasal base.